everybody. I am presenting about the journey of robotics from primitive era to the present day XI and S5 Da Vinci robotic equipment. Now we do robotic surgery in Hyderabad. We have two hospitals. One is in Medipalli, another in Gachibowli. Can I have next slide, please? The part-making journey of robotics in urology. Because we have been seeing this robotics for past 25 years becoming popular all over the world. In fact, I passed out urology in 1991, but in 2004, I was fascinated by the robotics which are being done in USA, Henry Ford system in Detroit, and then through some friends, I actually approached them to see whether I could learn the new facet of urology, that is robotic surgery. Next slide, please. This is our hospital in Medipattam. This is in Gachibowli. And robotic surgery is a new facet which was getting popular in USA, but not available in India at that time. But when I went there, I was told that robo is not in India. What is the use of getting trained in India? Because no such equipment is available. You can't even operate our patients with the robo. But when I went into the history of robotic surgery, you can see this is a wooden lion which was with Leonardo da Vinci in 1519 year, that he used to walk with this lion, and then as he walked, this lion was roaring. So when he entered the stage, suddenly people used to run away from the audience thinking that some lion has entered the hall, because the sound what it is made is extremely simulating that of a lion. There are about 66 joints in the head to make that sound of a lion's roar. Even in 15th century, which they could make such a wonderful equipment with a wooden panel. So why can't we make a surgical robot now in this century, in 2025? See, we have seen how it has been done. So many nuts and bolts, so many bits and bits, all of them accumulated and assimilated to make a lion's head. And Leonardo da Vinci was a Renaissance artist and a famous theologist. He had multiple theories, which also became popular posthumously also. So next slide, please. So that's how in 1927, Roy Winsley made the first humanoid robo, which is called as robot televax. This is a humanoid where it has got few buttons here. What he could do was switch on a TV or switch off a TV, open the door lock, or welcome a guest. This was done in 1987, but in 1937, next one, the electromotor man was prepared. This also was a robo, and he could smoke. You can see here he's smoking a cigarette, complete cigarette could be smoked, and here there are a lot of joints here which allowed the robot to smoke, and this man could answer the questions. He could welcome the guests, he could answer the telephone, he could actually, if you tell on the telephone that you switch off the fan or AC, it could do it. So this was a little more refined sort of a robot which was prepared in 1937. But as you come down the lane, next slide please. You can see here, this is the first robot citizen. Her name is Sophie, named after the beautiful Sophia Loren. This Sophie was made in 2016 by a Hong Kong based company, where they have assimilated a lot of human intelligence into the mind of Sophie. And you can see the lot of nuts and bolts here in her waist. She came to India twice. Can you go back on the slide? She came to India twice, and both times she interacted with the graduate. She came to Calcutta in 2024. Earlier she came in 2022. She has toured almost 65 countries, and then she interacted with a lot of intellectuals, engineers and research scholars who asked several questions to her, and she answered each one of them with extraordinary intelligence. And they were surprised that a robo, humanoid robo, prepared in Hong Kong by an Indian called Pandey, was doing so well. And every year it has been programmed for more knowledge. And for the engineering students, what she said was, as exams are nearing, prepare hard, but don't concentrate on memorizing. You concentrate on understanding the concepts. And hence, the next slide please. This Sophie had further skills, like it could actually write a sketch. If a person could stand in front of her, within seconds she could make a sketch of the person in front of her. So that was another facet. They thought that why not Sophie, which is just like a humanoid, make an expression. So there are a lot of machines inside our face which make her frown, or she can laugh, she can smile, she can be astonished. and such wonderful things. She can laugh. So the human expressions were given to Sophie by multiple programmable automatic switches, and hence the Sophie became world's most famous humanoid robot. And in 2016, the Saudi Arabia has given the citizenship to Robo. The Sophie is a Saudi Arabia Robo citizen. So it's a very famous citizen of Saudi Arabia, and it tours all over the world with the knowledge that she has attained over a period of last 9 years. Next slide, please. You can see here the surgical robots have been prepared since 1988, standard one, 1998, standard one, and in 2009 they got 3 arms. Earlier robots had only 2 arms. In fact, I visited Henry Ford system in 2004, and at that time the initial robo has only 2 arms. Later on SI had come. SI had 3 arms. You can see here Da Vinci is a HD model in 2006, and you can see here this is a Da Vinci XI made in 2014. They are all in the same line without getting clashed, and you can see the most famous and most latest Da Vinci model is Da Vinci 5, which gives a sensory feedback. The initial flaw of the robotic surgery was it doesn't have the feel of a human tissue, but this model Da Vinci 5 has made it possible that you can at least 43% of sensory feedback can be done by the help of the arms, which actually give the feel to the surgeon who is operating. Next slide, please. Now, as you see here, this is the initial robo, Leonardo da Vinci's mechanical night robo in 1495. You can see the next models, how they are. This is a single port robo. As evolution of surgical robots is going on, next slide please. There was another new model. You can see here 1998 to 2012, it is a standard model. 2006 to 2017, it is a Da Vinci S model, which is HD. 2009 it is Da Vinci SI. In fact, our robotic surgery is done in Da Vinci SI. And here 2014 is 2000 XI, and Da Vinci in 2017 is the latest model. Coming to all this, there has been another robotic model which is prepared in India. Because this Da Vinci is more expensive, it costs around 15 to 18 crores, which is quite high for an Indian hospital to afford. Hence, they have made an attempt. Next slide please. To find out whether a smaller thing, a cheaper one could be made. Now most of these things are done abroad. The multiple technology like Firefly system, and then the arms, the refinement in the sophisticated equipment was done. But the Da Vinci technology was a different one, which is making the local area surgery more possible, applied to the surgery in the similar setting or in the same hospital or in the same operation theatre. Next slide please. Now this is in Cleveland Clinic. I visited Dr. Robert Stein. I was there for fellowship there in 2013 in Cleveland Clinic, Ohio State, USA. Dr. Robert Stein is a famous robotic surgeon running around the operation theatres for different types of robots which are already docked, and assistants have put the ports inside. Next slide please. Now not only the Da Vinci, there are so many other evolutions like AESOP for positioning the endoscope, Zeiss and Vesalius, and Robotic, Puma for different facets of urological surgery of the robotic origin. Next slide please. Now you see here, this is a robotic surgery vision, which is an Indian-made SSI Mantra machine, which is most advanced, and then it is mostly applicable for the sophisticated remote surgeries, like surgeon sitting here and surgery happening in the war front or remote areas in an ambulance, where the ambulance also has a robo. Hence, the SSI Mantra made by Dr. Sridhar Srivastav, who is a cardiac surgeon, who has done a lot of endoscopic surgeries by robo and who holds a record for that in US. So he has actually thought of a robo which is indigenous, made in India, and it costs around 4 to 5 crores, which is affordable to most of the hospitals. Next slide please. It has got several facets, like it is a SSI Mantra, it's got SSI Maya for vision in the illusionary area to train the persons, and then their Mantra, Yantra, Maya. Yantra is the equipment of the robotic equipment of the SSI robotic instrument. This is an open console, it's more easy to learn, and whatever surgeries were done by Da Vinci also were done by SSI Mantra with equal ease, with equal comfort and equal surgical results. And most surgeons who have done surgery by Da Vinci robo have already also done and then certified that it's a safe and affordable for the Indian population. And there are a lot of applications, a lot of installations of SSI Mantra in India which are doing extremely well. Probably if the cost comes down, more and more hospitals could afford, and robotic surgery becomes more practical and affordable to a common man. Next slide, please. This is a photograph what was taken in 2004 at Henry Ford Health System. This is a, there are only two arms at that time. You know, these are the 3D lenses because it gives a 3D vision, and there is a learning screen on the back which shows only with 3D lenses you can understand what surgeon is doing. So this is a photograph 2004 with Dr. Manimenan and Dr. Peabody at the time. Next slide, please. This is also the photograph of Henry Ford Health System, Detroit, Michigan, USA in 2004. It had only two arms, one and two, and behind is a lens. But later on, they have added a third arm for complicated surgeries, and to see that it doesn't clash also is very important. Next slide, please. Oh, this is the faculty at that time, Professor Manimenan, the famous robotic surgeon. Dr. Peabody was director of the academic program, and taken in 2004 when I did the initial robotic training. Out of my own interest to know what it is, even when the robo was not there. In India, the robo came in 2013. So 9 years later, when robo appeared, then we had the chance to do the robotic surgery in India, which we learned long back. Next slide, please. Now, I'm showing some of the cases where the robotic surgery has been done. A 50-year-old obese lady went for a master checkup and found incidentally a small bump in the left kidney. Next slide, please. And then see, he had no urinary symptoms, she was in general good health, and then detected to be diabetic, but he didn't have any history of cancers. But this lady, next slide please, this lady actually had an ultrasound. There is 3 centimeter space occupying lesion on the left kidney, and CT scan showed this tumor to be in the mid pole of the left kidney. Next slide please. You can see here there is a small bump like thing on the left mid pole on the left kidney, and this is a plain CT on contrast enhanced CT. Next slide please. On contrast enhancement, you can see here there is a little bit of faint opacification, but not as good as the whole kidney. So this was found to be a small tumor on the convex surface of the mid pole of the left kidney, and we thought that we could remove it by robotic surgery. Next slide please. Now you can see here this bump is more prominent here. The opacification is a little less, but still it was merging with the walls of the parenchyma of the kidney. So by robotic surgery, we wanted to excise this part and then preserve the rest of the kidney and repair that. Next slide please. This is a CT scan showing the pelvical system, which was not distorted. It was normal. This is on the right side, this is on the left side, and here is somewhere here is a tumor which didn't actually involve the pelvical system. Next slide please. Now there is a video in this. You can see we are actually dissecting. This is the hilum. The pulsating one is the artery. Below is a vein. We are isolating. We are identifying the artery and vein clearly. After we identified, we actually put the bulldog clamp on the artery so that there is no bleeding while we do the excision of the tumor. And this is the artery what we are actually, posterior aspect of the artery we are dissecting, and then you can see the good pulsations there. After that, we are going on to the tumor where we are making a small marking around the tumor, what we have seen on the convex surface, with a 1 centimeter margin all around. After marking, we have cut open that area, and then because there is a bulldog clamp and hilar control is there, there is no problem in bleeding. So we have done the renography or repair of the kidney after excision of the tumor in the convex surface. You can see there is not much of bleeding. Still, whatever tumor is there, we have removed completely without any spillage of the cancer onto the normal renal parenchyma. You see here, this is a normal parenchyma here. We are dissecting off the tumor slowly, bit by bit, and then we could not find any calyces. This is on the posterior surface of the tumor that we are dissecting, and after the entire tumor has been dissected, we are suturing off. This is called renography, where we are actually taking bites on either side so that there is no further bleeding, there is no leakage of urine, or there is any further loss of parenchyma or blood loss even after it is sutured. So once the suturing is complete, we remove the bulldog clamp and see that there is no further bleed. And if at all there is some small bleed here and there, we can take reinforcing sutures later on. This is a V-lock suture we have taken inside. Initially the inner portion, and outside taking the renal capsule and the outer portion of the renal parenchyma. And this entire procedure was performed in about 18 minutes. So this is a good result after robotic surgery. Next slide please. Now post-operatively the drain was removed on second day. The patient was discharged on the second day evening itself. So hardly he had 3 days stay in the hospital. The histopathology has come as clear cell carcinoma. He is doing 14 months follow-up. After that also patient is doing well. Next slide please. Now there is another case called retroperitoneal fibrosis where a gentleman had pain in the back and his creatinine was rising. Next slide please. So we found that there is a hydronephrosis on the both sides because of some retroperitoneal fibrosis which is compressing on the ureters. Next slide please. You can see here this is a right kidney, this is a left kidney. They are enlarged, they are dilated. The ureters are drawn more medially and this ureter is compressed on both sides. So it was causing obstruction. So we have put a double J stent on both sides to save the kidney function. The creatinine was initially 3.5. Later on, after putting the stents, it has come back to 1.6. Next slide please. The stents, these are the stents placed inside. They could be passed easily without any obstruction anywhere. After about 1 week, the patient has stabilized. The creatinine has come back to 1.6 milligrams per cent. Hence, we operated by robotic surgery. Next slide, please. Now, the plaques of the retroperitoneum have been excised. First on the right side, then on the left side. They are very tough, very thick, and there are calcific spots also. Next slide, please. You can see there is a video on this. We are cutting through the retroperitoneal fibrotic plaque. We are very careful because we should not injure the ureter, and the ureters are actually very much deep inside the dense sheath. This is all the retroperitoneal fibrosis which was actually ensheathing the ureters. The ureters were compressed. So bit by bit we have excised this retroperitoneal fibrosis, and after the entire plaque was excised, we could see that the ureters were normal, they were not injured because they are already stents. We were able to identify it easily and did not go very close to it. Dense fibrotic plaques were around the ureter were removed, and once they are removed, the ureters were reperitonealized so that this sort of a retroperitoneal fibrosis, even if it recurs, it will not go through the reperitonealized ureteral segment. You can see here, this is a ureter inside. We have excised entire retroperitoneal sheath. Next slide, please. This is another video where around the ureter there is a calcific spot. This is a dense calcific. It was actually cutting through like a bone. So such dense fibrosis was cut off, and both ureters are freed. Next slide, please. The entire procedure took around 2 hours for us. So the patient recovered on second or third day we discharged him. There is a third case where there is a Mullerian duct cyst. A 22-year-old man presented with lack of secondary sex characters, and he has a lot of fat in the abdomen. He was being treated for hypogonadism with testosterone injections outside. He had some suprapubic discomfort. Next slide, please. So he didn't have the facial hair or chest hair, and he had right inguinal testis. So he came because the testis was little higher up. Somebody told that his hypogonadism is because of the testis being on the higher side. So we put it down. We have done the orchidopixy on the right side. Next slide, please. And surprisingly, we found on ultrasound 15 to 12 into 10 centimeter cystic lesion in the pelvis, and this showed on the CT scan that it is a pyriform shaped space occupying lesion in the pelvis between bladder and rectum. So we were surprised that in a male that a soft tissue is there inside his pelvis between bladder and rectum, and this man had undescended testis and then a cystic lesion. Next slide, please. This is how his abdomen looked. He had a lot of fat here, abdominal fat, and he actually female pelvic orientation, though he was a boy of 22 years. So next slide, please. So this is the testis in the right groin, which is undescended. So we have put it back into the scrotum, and after about 2 weeks or so, we have taken him for robotic surgery. Next slide, please. This is where the space occupying lesion is here. This is the rectum. This much big space occupying lesion here. It was surprising that what is inside is not clear. We have gone through is a chromosome karyotyping which shows 46XY. Next slide, please. Then we see on the longitudinal section, this is the bladder, this is the rectum. There is a vertical space occupying lesion looking like a uterus. So uterus is generally in the females, but in this man, something resembling a uterus is present in the pelvis. So probably it is a Mullerian duct cyst remnant. Next slide, please. You can see here, this is the same thing, the oblong or piriform shaped space occupying lesion. This is the left side, probably the left horn of the uterus. Next slide, please. This is a robotic port placement. Next slide. This is the, as soon as we enter the abdomen, this large, soft and pliable space of occupying region was there. When we pressed it, it was actually getting compressed. Next slide, please. We actually cut open. This is the one side. This is a dissection of the left horn. This is the left horn of the uterus or mullerian duct remnant, you can say. You can see this is the soft tissue what we are actually trying to separate from the pelvic area. There was dense fibrosis around with the pelvic wall, so we are trying to dissect out the horn from this side. So the left horn was more developed than the right horn. One after the other we have dissected from the pelvic structures. It was not very greatly adherent because it's a benign condition, and when the dissection was difficult, we punctured it with a needle and then aspirated thick mucus coming out from this. After decompression of this swelling, the surgery became easy for us. And then you can see here, there's some bleeders here which we have diathermized and then cut. So the entire mullerian duct cyst has been removed completely by the robotic surgery without injuring. The front is the bladder, behind is the rectum. So it was more close to the rectum than the bladder. So without seeing here, this how it is soft and pliable. It is flexible because of the fluid inside. And after we have excised completely, then we found that there is no further extension down into the pouch of Douglas or into the rectum. So it's a complex area between bladder and rectum, which is difficult to do by any other surgery. The surgical robo was very handy and useful for this sort of complicated and complex pelvic space occupying lesions. So the bleeding is very less, the vision is excellent. There is a 3D visualization and magnification which helped us to complete the surgery in about 1.5 hours. Next slide, please. This is how, this is the swelling and this is the pelvic wall. Next slide, please. This is what we removed from there. This is a big swelling what we have removed. This looks like a uterus. This is the left horn which is long. This is the right horn. And the pathologist has reported that is a endometrium. Next slide, please. He is a boy. Second day after surgery, he was up and about. He was able to take oral diet. We discharged him on third day. Next slide, please. The next slide, please. The present position here. He came after 1 year. He looks better. His abdominal fat has come down. Slowly, some facial hair, some mustache is appearing on him. Next slide, please. And this is another rare case where a 40-year-old man presented with lower abdominal pain, and his ultrasound showed 8.3 to 5.8 into 6 centimeter pelvic space occupation, probably arising from the prostate. Next slide, please. The MRI showed a large heterogeneous soft tissue mass in relation to right lobe of the prostate. We did a core needle biopsy of the pelvic mass, which showed spindle cells and in the mixed stroma, a moderate myotoid figures. It was probably a low-grade myxofibrosarcoma from the right lobe of the prostate. Next slide, please. You can see here, this is the bladder. This is the space occupying lesion like a cricket ball. This is the rectum. In the more zoomed area, here you can see here, this is the bladder, this is the rectum, and the swelling is in between the two, which is surprising. And then the solid and heterogeneous attenuation. Next slide, please. This is again we have shown in a zoom view that the bladder is pushed above, rectum is pushed below, and this is coming probably from some connective tissue element in the pelvis. Next slide, please. He is a man before getting anesthetized. Next slide, please. This is a surgical robo with a Da Vinci SI model what we are using in our hospital. Next slide, please. This is at the time of port placement and docking of the equipment. Next slide, please. Now, this when we entered into the pelvis, this is a large cricket ball like swelling here. Now this is a bladder pushed up. Behind is a rectum. Next slide, please. We have been extremely careful that we should not in any way encroach onto rectum because rectal injury is very common when you are dissecting on the posterior aspect of this swelling. Next slide, please. Now there is a video in this. You can see here, front is the bladder. We are actually going around the swelling bit by bit because we don't know what is the extension and what is the blood supply coming from which area, we are not sure. So as we are, this is the swelling, as we are actually opening it up, we are actually infiltrated with saline so that the dissection becomes more easy. Lot of fluid is seen here, it is not blood. And how the swelling is abutting between the bladder. This is the bladder here, this is the rectum here, and this is swelling here. It has got a smooth capsule all around it. So in this capsule area, we dissected out the capsule from the surrounding tissues without injuring the bladder or the rectum. In fact, we had a catheter in the bladder so that you could feel the bladder in between and the rectum. See, we were very close to rectum, but still we didn't injure it. We taking care, and sometimes we put a finger inside the rectum and then try to find out how far away from rectum we are after operating. You can see here, this is the connection there. The final connections here, whatever it had, we slowly cauterized them, and we have put a Kammela clip at the reasonably well-sized vessels. You can see here, this is the swelling separated totally. These are the small adhesions that it has to the pelvic wall, or it is the retro pelvic area, retro swelling area, in front of the rectum and behind the bladder. This is the pedicle which was supplying the swelling, which was around 5 millimeter vessel. We have actually put a Kammela clip on that. We have taken control of the gut circulation there. There was no bleeding. After putting a Kammela clip, we found that there are small bleeders all around, which we could actually control with the diathermy. And this is the way the entire area was actually dissected off. You can see here the final connection of the swelling, which is around almost 10 centimeter cricket ball sized benign tissue lesion. You can see here we are cutting off the final pedicle here, which is connecting. Here is the rectum, and here is the above is the bladder. And we put a Kammela clip so that the final blood loss is cut off. Blood supply to the swelling is cut off. Then we have cut it. You can see here there is a small bleeder, there is a small spurter coming from the below, from the bottom, which has actually caused some sort of a bleeding here in the base. And that also you can see here, there is a spurter here. The spurter here that we have taken control by diathermizing. And at the end of all this, there was no bleeding, no injury to bladder and the rectum. Next slide please. We have put the entire swelling in the bag. Next slide please. Next slide please. This is put in the bag, and then this is the next slide. And this bag actually it is almost around 500 grams. The swelling is around 500 grams. And then next slide please. After taking out from this is the sent to the pathologist. Next slide please. There was smooth recovery. There was 3 hours surgery here. Drain removed on 3rd day. Discharged over on 4th day. Next slide please. Now histopathology showed that probably spindle cell mesenchymal tumor of mixed origin involving the prostate. So this is a benign tumor. It's 4 years after the surgery. Patient is doing well. Every year we are doing CT scan. There is no sign of recurrence. Next slide please. This is the single port robotic surgery. Many people are a little scary about multiple holes here and there. So single port from the umbilicus, from the umbilical belly button, we can actually go inside. Next slide please, and do the entire surgery. This is a video in this. We will go through a single hole in the abdomen, that is through umbilicus. There is a central vessel, that the instrument which is going inside, and in this there will be provision for 3 instruments. You can see here, this is the camera. You should put in the light right here. The 2 working instruments come from here, from below, and then they will actually go inside, and we can do the surgery with the help of these 2 working instruments. Now this is the, you can see here, this is the, make an incision on the meat, piece of meat here. We are holding it and then making a cut on that. Making a cut here to show that we can actually make an incision, or we can suture whatever we have cut. So this is a diathermy, this is a forceps, and you can see this is a telescopic lens, all coming through the same hole. That is called single port robotic surgery, which is wonderful. After doing this incision, we are taking out these instruments and then trying to suture that with the another. This is a needle holder here. We are taking a needle holder. They are actually putting sutures here along the cut body we have made inside. So that's how we can easily make a incision, make a suture, or make any type of a tumor excision or reconstructive surgery. Whatever surgery in the urology or any abdominal surgery can be done through a single port. There is a torch effect here. We can make an incision. We can actually suture it properly so that person has only one hole which is actually hidden in the umbilical area. So many of the celebrities or in the media persons or some models, they don't like multiple holes on the abdomen or scars. For them, the umbilicus is the easiest spot where we can hide the incision, single port through which entire surgery can be done. So this is the most advanced part of the robotic surgery present day. There is a surgical dexterity, there is a magnification, there is easy manipulation, all through the single port, which is unimaginable but still possible in our present generation. So this is called port surgery, single port robotic surgery, which is the up-to-date latest information and latest dexterity of surgical instruments has been developed into this sort of a equipment. Next slide, please. Now, robotic surgery is the future of urology. There is a better access to the deep set areas. There is a 3D visualization and magnification, indoor instruments and pinpoint dissection, decrease surgical fatigue and tremor, and great help while dealing with complicated anatomy and adverse situations. Next slide, please. Thank you.